Hi all, welcome to today's session. Today we are going to see about the topic ruptured ectopic and other type of ectopic pregnancies. So let's move forward. First we'll have a brief intro about what do you mean by ectopic pregnancy and all. So we'll study first about ectopic pregnancy. Ectopic pregnancy is the implantation outside the uterine fertilized implantation of fertilized ovum outside the uterine cavity. So the most common site of this is here in fallopian tube. You can see in the picture below there. A ruptured ectopic is a surgical emergency and remains a major cause of maternal morbidity and mortality if not recognized early. So in this lecture, we will be focusing on the recognition of the condition and what are the investigations we will be doing further to diagnose it quickly and the clear stepwise management both in the IPD and as well as the OPD approaches. So here we'll see about all these things in the next upcoming slides. So first we'll see the sites of ectopic pregnancy. So where most of the time the ectopic pregnancy can happen other than the uterus. So remember these sites. What is tubal? It is one of the most common thing, and ambulary, isthmic and fimbrial, you can see there it can happen. Outside the tube we see ovarian, cervical, abdominal and scar ectopics. So that is scar ectopics is cesarean scars. So also be aware of heterotopic pregnancy, which is simultaneous like intrauterine with ectopic. So which is uncommon but important in the IVF or assisted conceptions. So that is also important. So here the site of this pregnancy is matters very importantly because the presentation, risk of early rupture and surgical approach differ in all the types of pregnancy. So for example, isthmic ectopics rupture earlier and with more catastrophic bleeding than ambulary ones. So we have to see where the site of the fertilized ovum and according to that we can diagnose the condition. So there are also different types of presentations when there are different type of risk also. So for that you have to be well aware of the sites of ectopic pregnancies. Next is the risk factors. So risk factors here is first thing is PID, pelvic inflammatory disease, previous ectopic pregnancy, like tubal surgery or sterilization, then intrauterine contraceptive device IUCD use, assisted reproduction like IVF and all, endometriosis, smoking, congenital tubal anomalies. So these are the risk factors of ectopic pregnancies, and in practice any woman with a history or a past PID or tubal surgery presenting with pain and positive pregnancy test should make you suspicious of ectopic pregnancy. So here that is the important thing. So you should be always aware of all the type of risk factors so that it will be very helpful for you to diagnose the conditions correctly. So these are the risk factors of ectopic pregnancy. Moving on to the pathophysiology. Pathophysiology is simple and clinically very useful also. So when there is a delay in passage of the fertilized ovum through the tube, that can get implanted within the tube, that leads to a trophoblastic invasion which erodes the thin tubal wall, which leads to bleeding and eventual rupture. So poor remodeling of spiral arteries, or when the ectopic conceptus is abnormal in location, which can lead to progressive trophoblastic growth and weakness of the tubal wall. Clinically, this explains why rupture commonly occurs around the 6 to 10 weeks of amenorrhea, depending on the site and rate of trophoblastic growth. So, that is a very important why ischemic occasion causes the early rupture. So, this is how the pathophysiology or physiology happening in the ectopic pregnancy, ruptured ectopic pregnancy and all. Next, moving on to the clinical features. So there is a classical triad in the ectopic pregnancy: amenorrhea, abdominal pain, vaginal bleeding. Amenorrhea will be 4 to 6 weeks, abdominal pain, vaginal bleeding. So always remember this classical triad. But remember, this is not always complete. And pain is the most consistent symptom. Usually there will be unilateral pain. Look for shoulder tip pain. That is a red flag for irritation from hemoperitoneum. So look for that. On examination, you may find pallor, tachycardia, abdominal tenderness, or gaudy. And there will be peritoneal signs also if ruptured. And on bimanual examination, a tender adnexal mass with cervical motion tenderness will be present. So importantly, vaginal bleeding can be minimal even with a large intra-abdominal bleed. So don't be reassured by little vaginal loss. So always remember, always check the vitals and don't only rely on the vaginal bleeding count. So you should be very quick enough to know. So you should be aware, so that for you it's very important to know the clinical features in the ectopic pregnancy, so that you can differentiate it and diagnose the conditions accordingly. Moving on to the differential diagnosis. So important differential diagnosis which includes here is threatened or incomplete abortion, acute appendicitis, and hemorrhagic ovarian cyst, ovarian torsion, and PID. And in early pregnancy, pregnancy of unknown location is a useful working term. And always keep an open mind and use investigations to differentiate it. So one question I have for you is, which sign helps to differentiate appendicitis from ectopic pregnancy? Anyone knows that? The answer is migration of pain, localized peritonism in right iliac fossa. So that will be present, and you can use imaging techniques also for that. So that is a sign which helps to differentiate appendicitis from the ectopic pregnancy. So that is the importance of differential diagnosis while treating any conditions, basically mainly the ectopic pregnancies or ruptured ectopic pregnancies. Next is the investigation. So for us to diagnose the condition and to know and to get a rapid and focused results, you should be aware of the investigations you are supposed to do. First one is urine pregnancy test, which will be positive in ectopic. Second, you can go for serum beta HCG. In ectopic pregnancy, it will be the rise is slower than the normal. So doubling every 48 to 72 hours is expected in intrauterine viable pregnancy. But serial beta HCG helps to so in this serum beta HCG in ectopic pregnancy, it will be lower than the expected for gestational age. There will be no doubling rise. And serial beta HCB, which will also help us to decide the expectant versus the medical therapy also. So that is the second thing you can do. And third is transvaginal ultrasound, that is TVS, is the diagnostic pillar. Look for an empty uterine cavity, adnexal mass, tubal ring sign, or free fluid in the pouch of Douglas. The next thing is like the beta HCG level above which a TVS, that is transvaginal ultrasound, should show an intrauterine pregnancy. And it varies between labs also. So check your units cutoff, commonly approximately 1500 to 2000 ml. So you can go for that. Fourth is culdocentesis. Culdocentesis is the historical but can show non-clotting blood in the cul-de-sac in the unstable patients. So there will be presence of non-clotting blood present. Next, you can go for diagnostic laparoscopy. That is very definitive, and when imaging technique is inconclusive, you can go for that to confirm to do a confirmatory in doubtful cases. Also, always send CBC, blood grouping and cross match, coagulation profile, LFT, RFT in suspected ruptured cases. Uh, Here, which very important is if beta HCG is high and transvaginal ultrasound is empty, think for ectopic pregnancy or early intrauterine pregnancy with implantation very early. So repeat the test or proceed if it is unstable. So that is the important point here, investigations. So that is all about the ectopic pregnancies. Moving on to the ruptured ectopic pregnancy. Ruptured ectopic pregnancy presents acutely when you can see the patient will be having sudden severe abdominal pain, signs of shock, pallor, tachycardia, hypotension, distension and guarding, and the vaginal bleeding may be present minimal, and but immediate priorities are resuscitation and preparing for the surgery. That is very important, don't delay the things. So what are the steps you have to do is, first one is airway, breathing, circulation, ABC, to secure airway and give high flow oxygen. Second, you can go for two large bore IV cannulae, give crystalloids, start blood transfusion early if shock or falling hemoglobin present. Send urgent labs reports like CBC, cross match, coagulation, beta HCG group, and save. Insert urinary catheter to monitor urine output, which should be greater than 30 ml per hour. That should be the target. Prepare for pregnancy. Prepare for emergency laparotomy. So laparoscopy only if resources and patient is stabilized, you can go for that. Give analgesia and broad spectrum antibiotics peri-operatively. So here, like in an unstable patient, you must act on clinical diagnosis. Do not wait for the formal transvaginal ultrasound report if the patient is hypotensive and peritonitic. So that is the important part of ruptured ectopic pregnancy, and what are the things you have to do, and what are the steps you have to do in very rapid and focusedly in treating the condition of ruptured ectopic pregnancy. Moving on to the OPD management. So OPD management, while talking about OPD, the some small unruptured ectopics in stable patients can be managed non-operatively in OPD basis. First thing you can do is expectant management. So declining the beta HCG and minimal symptoms for that, or medical therapy with methotrexate. So what the criteria for methotrexate typically include to the, like when the patient is hemodynamically stable, there is no significant pain, and mass is less than 3.5 to 4 centimeter, no fetal cardiac activity, normal LFT RFT, and reliable follow. This should be the criteria for methotrexate. Methotrexate include the usual single dose protocol is methotrexate 50 mg per m2 im. Then measure beta HCG on day 4 and 7. Expect a greater than or equal to 15 percentage fall between day 4 and day 7. So if fall is inadequate, consider the second dose or surgical management. And there are also contraindications which include breastfeeding, active pulmonary disease, hepatic or renal impairment, or beta HCG beyond the local cutoff. Counsel the patient clearly about the side effects and strictly follow up. Advise contraception for at least 3 months after methotrexate. So institutional protocols vary. So follow your units expect exact beta HCG cutoffs and follow up schedule. So that is how you have to manage the condition on the OPD basis. I hope you got clear idea how to do it. Next, we'll move forward to the IPD management. So in case of ruptured ectopic or in surgical. So IPD management is for the severe severe presentations or ruptured cases. The key steps involved is resuscitate, stabilize, then go for a definitive surgery. If the patient is unstable, perform emergency laparotomy, midline or phalansteal depending on the surgeon. Evacuate hemoperitoneum and control the bleeding. Then what are the surgical options present is salpingectomy, that is the removal of the affected tube. That is common for ruptured, badly damaged tubes. You can go for salpingectomy. Next, you can go for salpingostomy, that is the incision and removal of the pregnancy while preserving the tube. Maybe consider if fertility preservation is a priority and contralateral tube is normal. Then laparoscopy is preferred when patient is stable and skills are available. And what are the post-operative care you can give is monitor the vitals, urine output, abdominal drain if placed, give antibiotics, and analgesia, and transfuse as required. Don't forget anti-D immunoglobulin for Rh negative mothers within 72 hours. And if there has been feto-maternal bleeding, you can go for that, and provide counseling about future fertility and contraceptions, also options. So that is also very important. So in IPD, you have to remember is when the patient is unstable, go for laparotomy, and if it is stable, then you can go for laparoscopy. So that is the important thing you have to keep in mind while treating the patient in IPD management, especially for the ruptured ectopic pregnancy cases. Next is the complications. Complications of ectopic pregnancies and ruptured pregnancies, which includes hemorrhagic shock, severe anemia, peritonitis, DIC, sepsis, and potential infertility from loss of tube or adhesions. So these are the things, and there can be psychological sequelae or psychological trauma, with, like, for example, grief and anxiety about the future fertility. So these are things are very common and must be addressed in follow up. So that is very important, because in this psychological trauma cases, very important to follow up the patients accordingly and give a proper education and proper counseling after such incidents. So that is very important. So these are the very important complications you may see in the ectopic or ruptured ectopic pregnancies. Moving on to the preventions. So how you can prevent the condition. Prevention is linked to, like, you have to reduce the risk reduction. So treat the pelvic infections properly and early diagnosis is very important, and treatment of pelvic infections is also important. Always educate them and counsel them for to practice safe sexual practices. And you should also give caution, regarding the cautious use of IUCDs, uh, intrauterine contraceptive devices, and ensure timely follow up after tubal surgery. In assisted reproduction, like assisted reproductive techniques like IVF and all, counsel the patients about the small risk of heterotopic pregnancy, and keep a low threshold of early transvaginal ultrasound. So encourage early antenatal booking so ectopic pregnancies can be detected before rupture. So these are the short list of practical preventive measures you have to tell patients regarding it, so that it will help to prevent any such kind of risk during the pregnancy type, especially in the early pregnancies. So that's it about the prevention, and let us just summarize about today's topic. In ectopic pregnancy, as we have discussed, it is an implantation outside the uterus, commonly in the fallopian tube or tubal, and the clinical triad is amenorrhea, pain, and bleeding, but the presentation may varies. Transvaginal ultrasound and the serial beta HCG or serum beta HCG are the very important diagnostic tools in the ectopic pregnancy and ruptured pregnancies. And management depends upon the stability. So medically, you can give methotrexate, or expectant for selected stable cases. Surgical also you can do for unstable things, stable unstable things. If it is not able to manage, you can go for surgically. You can do salpingectomy or salpingostomy. And for ruptured or failed medical therapy, so failed medical therapy and case of ruptured ectopic pregnancy, you can go for surgical. Next important thing is always resuscitate first in the unstable patients and give anti-D to Rh negative mothers. And early detection is very important, and protocol care save lives and preserve fertility when possible. So that concludes about today's lecture. I hope you got the difference between the types of pregnancy, ectopic pregnancy and ruptured ectopic pregnancy, and how we have to treat in IPD and OPD basis, and what are the risk factors behind it, and what are the complications you should be aware of. And as well as how to prevent it. So prevention is also important. So we have discussed all these things in today's session. Hope you got a clear idea regarding it. Thank you so much and have a nice day.